Hello and welcome to the Health Podyssey. I'm your host, Alan Weil. We've heard a lot about private equity in healthcare in the last few years, and we've discussed it a number of times on this show. Private equity now plays a role in hospitals, medical practices, nursing homes, hospice, pretty much everywhere you look. But what about dental practice? Is private equity coming to a dental practice near you? Well, that's the topic of today's episode. I'm here with Kamyar Nasseh, a health economist at the American Dental Association. He and colleagues analyzed provider data from 2015 to 2021 to examine trends in private equity affiliation of dental practices. That work is published in the August 2024 issue of Health Affairs, and it showed significant growth over that period in the role of private equity. We'll discuss these findings and their implications in today's episode. Dr. Nasseh, welcome to the program.
Thank you very much, Alan.
So as I mentioned at the outset, we've talked a lot about private equity in general on this show about healthcare, in the domain of healthcare. So let's focus in on dentistry. What is it about dentistry that might make a private equity firm interested in acquiring a dental practice?
Alan, before I answer that question, I just want to state that any views expressed in the paper or in the podcast do not necessarily reflect the views of the American Dental Association as a whole.
I do appreciate that, and we'll make sure our listeners are aware. Thank you.
So regarding your first question, why might private equity be interested in dentistry? That's a very good question. Well, compared to other parts of healthcare, dentistry, dental practices are fairly fragmented. There are many locations. Historically, dentists have worked in solo or small partnership or small group practices, but that is changing. So private equity may see an opportunity to enhance what we call in economics economies of scale or enhance efficiencies. So for example, potentially, we didn't explore this in this paper, one example of that would be, let's say I need to get a root canal. I would see my endodontist, right? And then I would need a crown a couple weeks later, and typically crowns are placed by general practice dentists. Usually these dentists are in separate locations. So maybe private equity will want to put the endodontist or general practice dentist into one location. Now, we didn't explore that in this paper, but that's potentially one example of how private equity could enhance efficiencies in dental practices.
And that's very familiar. Certainly with physician practices, we see the transition from sort of the solo small group to consolidation, and some of that is financed by PE. Now, on the healthcare side, I'll say we've published enough to show, I think, fairly definitively that there are risks of price increases and potentially equally or more concerning, some quality concerns, particularly driving high cost utilization that may or may not be necessary. Those are the risk factor, or the risks that people on the healthcare side focus on when they look at PE investment. Is there any evidence of similar kinds of practices in dentistry? Or are we still sort of not at are we still more at the descriptive stage?
Right now, that's a very good question. Right now, we're at mostly the descriptive stage. I do like to point out that we are working on exploring private equity's effects potentially on prices and service mix. That is research that it's currently ongoing. I do not want to disclose the results of those results yet, but we are looking at that.
Yep, completely understand. I mean, I guess given what we know from the medical side, it's a hypothesis worth testing, and we'll see where that takes us. Now, before we get into your findings, I think it's important we put into the conversation this dental service organization, the DSO. Just like when we talk about private equity in, say, nursing homes, we have to start talking about REITs and other management structures that are management contracts that, again, pose certain opportunities for efficiency, but also risks. So can you just explain to our listeners first of all, what is a DSO and why, when you're talking about private equity, do you need to be thinking about DSOs as well?
Let's think of a dental service organization or DSO as a sort of platform. These platforms and the physician side are typically called physician management organizations. So these organizations typically handle administration, HR, billing, business functions for dental practices, so dentists themselves don't have to take on those tasks. And what we actually see, if you look at as we were collecting the transaction data, what will typically happen is either a private equity entity will buy an existing DSO or invest into an existing DSO or start a new DSO and build from there. But essentially, these DSOs are platform organizations that handle business, marketing, billing, maybe price negotiations with insurers on behalf of dentists.
And so that's, again, sort of, as you noted, it has its origins or corollary in the PSO. So the idea here is basically going back to the sort of the narrative we had earlier. On the one hand, they are a vehicle for increasing efficiency. At the same time, they're a vehicle for potentially altering practice, and at least we see this in the healthcare space. I don't want to accuse it in the dental space until we have the data, but we see it as a way to pull resources out. That if you have a contract with an organization that you control, then you can decide how many dollars flow into that, and that can be a way to pull resources out and get some returns. So sort of both the positive and the risk side associated with this intermediary.
For example, I'm sure maybe the readers, your listeners are aware of like Aspen Dental or Cool Smiles. These are examples of DSOs, many of which are private equity backed. In fact, roughly 9 in 10 DSOs have some sort of private equity backing.
So it's quite integral to the story. So let's jump to sort of the punchline here. You analyzed the role of private equity in dental practices. What can you tell us about the rates that you saw in the period you studied? And particularly, once you give that sort of top line, you did find some variation around practice type and region. And obviously, our listeners can go to the article if they want every bit of detail, but maybe you can paint a picture for them.
What we found is that roughly the percentage of dentists affiliated with private equity almost doubled from 2015 to 2021. Roughly, I believe, from 6.6% to 12.8%. Over the same period, we also found basically a doubling in the percentage of offices or locations affiliated with private equity. What we've seen in the transactions, the number of transactions, is this accelerating of the number of private equity transactions in dental between 2015 and 2021. Other than maybe a small dip in 2020, possibly due to COVID, the volume of transactions accelerated.
And then you looked at practice type, and you have a little data on region. Wonder if you can say a little more there.
Oh, yeah. So by specialty, that's very interesting that we found that private equity is attracted to practices in the Sun Belt or in the Southwest, Georgia, Florida, Texas, Arizona, Nevada. There's less private equity penetration in New England or in the mountain states, Montana or North Dakotas. So basically what this may suggest is that private equity is attractive to high growth areas, meaning areas that are growing in population, areas that may have higher household incomes, median household incomes.
And interestingly, you note in the paper, they're similar geographic variation on the medical side.
Yes.
So there is something in the water or in the air or in the regulation, in the structure of practice. Something seems to be common across these places. Be interesting to see what you find as we understand those differences. Also, practice type, specialty, and the like.
So typically private equity has been attractive to specialist practices, oral surgeons, pediatric dentists, endodontists, relative to GP or general practice dentists. Now we've seen substantial growth in private equity affiliation across all specialties, but we're seeing, particularly among more specialized services such as oral surgery, endodontics, periodontics, greater private equity affiliation. Now, why is this? One hypothesis is that these oral surgeons or endodontists perform high cost or high price services, so there may be greater opportunity for private equity to generate revenue compared to a general practice dentist.
Well, I want to go a little deeper into sort of what we make of this and where we might be headed. We'll cover those topics after we take a short break. And we're back. I'm speaking with Kamyar Nasseh about dental affiliation with private equity. We've covered sort of the basic findings here, which is near doubling in the period studied 2015 to 21, with some geographic variation and a focus on specialists, although there's growth pretty much everywhere. Now, as we discussed earlier, sort of what to make of this is still a story to be told. I think it's fair to say that the amount of analysis done around PE in dentistry is a little behind the rest of healthcare, but in all of it, I think the research is way behind what's actually happening out in the field. I want to bring a topic to you. It's a little complicated, but I think it's important. It certainly is the first thing that came to my mind when I think about the price and primarily the price effects in healthcare. Around private equity, I'm aware of the role of private insurance and although there's some concentration in the insurance market, there usually a fair number of insurers. They may be competing against each other, and all of the consolidation, private equity. I mean, it's a lot of different topics that I'm lumping together, but they play out in this in the context of a multi-dimensional insurance market. My recollection from my past reading is that the prevalence of dental insurance is significantly lower than medical insurance, and also that there aren't as many carriers typically. And so I would expect the market dynamics that private equity can employ when it moves into dentistry are going to feel a little different than they do in the rest of medical care. But I'm not exactly sure. So I just want to toss that topic out to you and let you tell me what you think about it.
So you actually make a very good point of how the dental market differs from the wider healthcare market as far as insurance or maybe out-of-pocket spending. So, and we, as a part of the Health Policy Institute of the American Dental Association, every year we publish data on the distribution of spending between out-of-pocket, private insurance, public insurance. So roughly, unlike medical, unlike the wider healthcare market, roughly 40% of total dental spending is out of pocket. I believe roughly 35 to 40% of total dental spending is from private insurance. On the medical side, the percentage of total spending that's out of pocket, it's much lower. So that begs the question is that if prices were to change, how that would impact consumers. in the economic parlance, we have on the price terminology, we have what are called list prices, what the dentists submit to insurers, or the submitted fee, and the allowed or negotiated amount, what the dentists receive from the insurers. Roughly, the submitted amount is 20 to 40% higher than the allowed rate, typically for a typical procedure. So if dentists were to increase their list prices in response to private equity transaction or private equity acquisition, that consumers could potentially be exposed to that higher price. If what's changing is the list price. Now, it's a question, and then we need to do more research on this. How do negotiated prices change? And what's the interplay between dental payers and practices?
Yeah, this is very complex.
It's a very complex topic, I guess.
Yes, but I like the way you approach it. I mean, I think the risk of higher out-of-pocket costs is greater because of the larger share in general of costs that are borne out of pocket. Of course, the economist says that may reduce demand. So, if you price yourself too high, people may not get services, not something we want here. But then also this very complex dynamic of whether it actually could lead to higher negotiated prices, which would increase premiums, but wouldn't increase the out-of-pocket side so much. Well, it'll be, again, I think what we're watching, unfortunately, on both the medical and dental side is market changes that are happening faster, frankly, than our data can keep up with. And so we can build a lot of hypotheses, and then we're kind of looking in the rearview mirror to figure out what effect some of these changes may have had.
So one may agree that dentistry is behind where physicians were maybe 20 years ago, where hospitals were. We know hospitals have consolidated, physician groups have consolidated. This has happened all over healthcare. Pharmacies used to be your community pharmacies, your local neighborhood pharmacies, and now Walgreens, CVS. So we saw consolidation on the pharmacy side, consolidation on the medical side. It remains to be seen how much consolidation happens on the dental side. Again, we need to do more research on this, but it seems that the same forces that impacted the medical side or the pharmacy side potentially could affect dentists going forward.
Right. And we think, well, the pharmacy is local and the dentist is local, but we still see that kind of consolidation. So maybe this is a good place for us to end our conversation. Despite doubling, the rates are still pretty low, as you said. 6 point something to 12 point something. We're not in the 20s, 30s, 40s. There's a long way you can go up from 12.8%. So, is there anything in the data or anything else in your work that would give you reason to think that this is a curve that's going to stop? Change shape back to slowing down growth? Obviously, you can't double forever, but or do you, as I think you just mentioned with respect to consolidation, do you think when it comes to PE, similarly, we're sort of in a growth phase, and we're just going to have to watch it grow for a while and see where it takes us? Certainly,
we're going to need to watch this going forward. But what we do know is that practice modality is changing, and we've published. As a part of the Health Policy Institute and the American Dental Association, we've published data showing that the percentage of dentists in solo practice has steadily declined over the last 10 years. More dentists are joining group practice. So we know practice modality, who dentists choose, the types of practices dentists choose to work for is changing. A lot of younger dentists are joining these large group practices. So these are all trends that we need to keep an eye on going forward.
Well, Dr. Nasseh, thank you for doing this work and for teeing up what is clear to be additional topics that we're going to be interested in. The shifts are consequential, they're large, and we're in need of not just the raw data, but also the analysis to try to tie these data to changes in practice, changes in price, maybe changes in quality and outcomes. And we'll be looking to you and your colleagues for more of that in the future. Thank you so much for being my guest today on a Health Podyssey.
Thank you very much, Alan.
Thanks for listening. If you enjoyed today's episode, I hope you'll tell a friend about a Health Podyssey.